Dear Professor Pollack, dear HPP colleagues, it's my great honor to be here. I'm Dr. Tian from Eastern Hepatobiliary Surgery Hospital, Shanghai, China. Today, I would like to share with this topic risk factor, patterns, and outcomes of late recurrence after liver resection for hepatocellular carcinoma. It's an over 15 years multicenter cohort study. I have nothing to disclose. In 4 parts. Background. As we know, HCC is a very common malignancy, and half of patients with HCC are in China. Liver resection is a mainstay of curative treatment for HCC. However, the long-term survival remains unsatisfactory due to the high incidence of recurrence and up to 70% at 5 years after surgery. Generally, post-recurrence can divided into early recurrence and late recurrence. And the early recurrence within 2 years after surgery is most likely the real metastasis from the initial tumor. And the late recurrence more than 2 years after surgery is most likely multicentric occurrence or de novo cancer formation. And the numerous previous studies have shown that risk factors of early recurrence include large tumor size, multiple tumors, high AFP level, and macro and microvascular invasion. However, risk factors, patterns, and treatment and outcomes of late recurrence after resection of HCC were still little known. To solve this problem, we conduct this retrospective study and methods. And we enrolled patients who were recurrence-free at 2 years after curative resection of HCC from 2001 to 2015 in 6 Chinese hospitals. And the endpoints of this study include risk factor and the patterns of late recurrence, and the treatment mortality for patients with late recurrence, and overall survival of patients with late recurrence. And patients were followed up using unusual used surveillance strategies adopted by all the centers for post-operative recurrence, including several AFP level and test and ultrasonography and CT or MRI. We recommend this patient after the first 6 months after surgery, recommended once every two months to do surveillance, and the next 1.5 years, and recommend once every 3 months to do, and over 2 years, once every 6 months. But in real world, not all of our patients stick to this surveillance, as you know. So we defined regular surveillance as abdominal imaging and all AFP surveillance every 6 months or within 6 months prior to the diagnosis of HCC recurrence. And irregular or no surveillance was defined as surveillance of more than every 6 months or diagnosis of HCC recurrence because of symptoms or because the patients were investigated for other reasons. So the result, this is a slide shows that the flow diagram of our patient population, and there were 734 patients who were alive and recurrence-free at 2 years after curative resection of HCC. Among them, 303 patients developed late recurrence. And as for the general characteristics, there were significant difference in general characteristics in the etiology of liver disease, as well as the percentage of cirrhosis. As for the tumor-related characteristics, there were significant differences between these 2 groups in the percentage of satellite, macro, and microvascular invasion and poor differentiation. And there were also significant difference between these 2 groups in the percentage of anatomical hepatectomy, the type of, and the resection margin. And this slide shows that the Kaplan-Meier curves show that patients without late recurrence have a significant longer survival than those with late recurrence. And the multivariable Cox regression analysis showed that independent risk factors of late recurrence include male cirrhosis, multiple tumor, satellite, maximum tumor size more than 5 centimeters, and macrovascular invasion. As for the patterns of late recurrence, there were 19% of patients got the intrahepatic recurrence, and only 10% of patients have intrahepatic and extrahepatic recurrence, and there was none of patients with got only extrahepatic recurrence. And among the 303 patients with late recurrence, there was 165 patients suffered from the potential curative treatments, including resection, local ablation, liver transplantation. And comparisons between patients on the regular and non or irregular recurrence surveillance, they show that significant difference in variables cirrhosis, portal hypertension, serum AFP level, as well as tumor stage of late recurrence and the patterns of late recurrence. We should note that the patients on the regular surveillance had more chance to get the potentially curative treatment than those patients with irregular surveillance. So this slide shows that the overall survival of patients with regular recurrence surveillance was significantly longer than those with no or irregular recurrence surveillance. So the multivariable Cox regression analysis showed that the independent predictors associated with overall survival in patients with late recurrence include post-operative surveillance, cirrhosis, portal hypertension, child path grade, tumor stage of late recurrence, as well as the treatment mortality for recurrence. So, ladies and gentlemen, let me get the conclusions from our study. The first one, late recurrence after HCC resection was associated with sex cirrhosis and some aggressive tumor characteristics from the initial HCC, suggest our traditional conception about late recurrence maybe should update. So the second one, the patterns of late recurrence suggest surveillance for recurrence after 2 years of surgery should be targeted to the liver. The third one, regular post-operative surveillance improved the chance of potentially curative treatment with improved survival outcomes in patients with late recurrence. So luckily, this paper has been accepted by JAMA Surgery last week. Many thanks to Professor Pollock. So I'm apologize to Journal HBB because I was also an editor at HBB. So thanks to my mentor, Professor Wu, and Professor Lau, and Professor Shen, and Professor Mara Schwartz, and the Cooperation Center's partners, and my young team. Thanks for your attention and hope for cooperation in the future. Thank you.
So this very nicely presented paper will now be discussed by Professor Tosilli from Italy.
First of all, congratulations, as usually in the